Right, that's a very common question which each and every patient asks and wants to know. Some patients didn't know about partial knee replacement. They come asking whether I'm suitable for a partial knee replacement or not. Any indication for any artificial knee joint is first, they should be quite symptomatic, which means based on the symptoms, they should be symptomatic enough to need a replacement surgery where they have expired or used up all the non-operative measures. The X-ray taken should show that there is full thickness cartilage loss, means there is arthritis or the slippery lining of the bone has worn out. That's radiological. Plus, on clinical testing, they should be suitable for a partial knee, which means that the other part of the knee, other 2/3 of the knee, they are not symptomatic. We do that by various measures. One is X-ray, another is by doing some tests on the table in the clinical room. And other thing is about the patient's understanding about a partial knee versus total knee. There are certain people who don't know about a partial knee replacement. If you ask them that, yes, you're suitable for partial knee replacement, and they ask, why can't I have a total knee? That means that they don't know the risks, benefits of it. In those patients, if we offer it, you often will have bad results, because at the end of the day, what the patient expects from an artificial knee is also important. And other thing is about the level of activity. If a person is much younger, higher level of activity, goes out on hiking and stuff like that, partial knee is better because it preserves the patient's both cruciate ligaments, and the other 2/3 of the knee is the same. So it behaves more like a normal knee, not exactly, but more like a normal knee. Whereas a total knee replacement, we have to remove quite a lot of normal structures. So it behaves quite abnormally, means it moves in different directions. And especially if you're doing high level activities, it involves twisting, turning, cutting, where the ACL ligament are required, they get more pain because the knee moves about and gives a little bit of wrenching feeling to the knee. So for high level activity patients is ideal. Now on the other extreme, it's good for people who are of old age as well, because it's a very less traumatic surgery. And if the results are as good, why not offer it to the older people as well, where they will do equally well with the total knee, but the morbidity or the risks associated with a total knee replacement is higher. So overall, it's suitable for all across the board: young patients, old patients, fat patients, slim patients, provided they are suitable for it, provided they understand that both partial knee and a total knee are artificial joints. There will be some residual pain, but there will be more residual pain and restrictions with a total knee than with a partial knee. So patients should understand that and should expect that, yes, there would be some residual pain, but it will be better than what a total knee can provide. Most patients, when the knee starts to wear out on the inside part. It's called medial compartment arthritis. That's called primary osteoarthritis. That means exact cause is unknown, but it's encoded in the genes. If the patient has got, and 9 out of 10 times it starts on the inside part, so you assess the patient by symptoms. If they point with the finger that the pain is always on the inside part, and on testing, there's no pain on the outside part and the patellofemoral joint, they are suitable for a medial compartment or inside compartment partial knee replacement. Very occasionally, they have arthritis on the outside part of the compartment. It can happen due to, say, previous trauma, fracture. Sometimes in olden times, when people had meniscal tears, they used to have a thing called open meniscectomy. Means with a small cut, the shock absorber was taken out completely. Invariably, that led to arthritis 15, 20 years down the line. So those patients, they are suitable for what we call as lateral compartment partial knee replacement. Again, the assessment is the same by the symptoms, by radiological means, and by clinical means, to make sure that the inside part and the back of the knee part is not painful or symptomatic. Very occasionally, the arthritis can be in just the back of the knee part. It's called patellofemoral. There are very few patients who are suitable for partial knee replacements, primarily because usually it's a arthritis which precedes the lateral compartment arthritis, means outside the knee. So back of the knee wears out, 3, 4, 5 years down the line, the outside part of the knee starts wearing out. So that's why it has got a bad reputation in terms of higher failure rate. The reason is that if you do something 5 years down the line, they will have arthritis on the outside part. Whereas by doing a medial and lateral unicompartmental replacement, you can realign the knee. With the back of the knee replacement, a surgeon has got no control over that. But if somebody has had a previous injury and a fracture, then they are suitable for partial knee replacement, then they benefit from it. Usually people had, say, lateral subluxation when the kneecap went out to the other side, or other malformation. Sometimes people are born with a thing called a trochlear dysplasia, where there's no groove in the back of the thigh bone. Is quite flat, so the knees tend to slide about and gets arthritic early in life. So those are the patients who are suitable for patellofemoral replacement. So again, depending upon whether it's the medial means the inside part, the outside part, or the back of the knee part. For the inside part, there's a thing called medial, minimally invasive medial parapatellar, where you cut just besides the patellar tendon. You don't cut any tendon, you move the kneecap to one side and perform the surgery through a small incision. It's called minimally invasive approach. For the lateral side, again, you can either have a complete cut the whole knee. In that case, the whole quadriceps tendon and the main tendon, which moves the knee up and down, has to be cut. Or it could be done through a MIS, minimally invasive, small lateral parapatellar approach. Means the incision or the cut is to the outside part of the knee, and small trauma, no tendons are cut, recovery is much faster. For the back of the kneecap, you can do two approaches. One is the standard one where we have to cut the tendon, or I normally do what is called as a subvastus approach, or a MIS approach, in which the tendons are not cut, the muscles are moved to one side, and the kneecap is turned upside down, and then you do the replacement surgery. So for patellofemoral replacement, I always do the MIS approach to the knee, where I don't cut the quadriceps tendon. Recovery is much faster. Any surgery has got complication. Even having a injection can lead to abscess infection. Similarly, any surgery will have infection. There are general complications, which is like infection, clots can form, go to your lung, but all these are much less with the partial knee. Specific complications specific to this partial knee is that it has only the half the bone is cut. So if the patient tends to walk about or do too much activity in the first few weeks, there's a thing called periprosthetic fracture, where the fracture, the cut where you have made a small cut, longitudinal cut, that propagates and causes a fracture of the bone, because it's only half and not complete. So half part is metal, half part is their own. So there is a thing called stress riser. One side is more stiffer than the other. In the first 6 weeks when it's healing, if person does too much or stumbles or have a fall, it can cause a fracture. That's number one. And the other thing is that the most common partial knee replacement has got a plastic which moves about inside and is free to move about. It's called meniscal wearing. Sometimes that can pop out of its place, which means a small operation to replace it back. It's called an Oxford partial knee replacement with mobile bearing. For the last few years, the design of the plastic has been changed to minimize that occurrence, and it has been reduced to quite a significant level. So those are those specific ones. Apart from general complications, like people have numbness on the outside part of the knee, there would be a scar tenderness, kneeling would be slightly difficult for a while. Common complications with oozing from the wound. Wound can take more than 2 weeks to heal. Infection is really, really rare. 1 in 500 compared to 1 in 100 or 150 for a total knee. So, and general complications, because the smaller surgery, less trauma to the local tissues, less trauma to the body. So general complications are far less with a partial knee than a total knee. I always tell people that success of any replacement surgery should be measured in years and decades, not minutes, centimeters, or days. Having said that, partial knee replacement is only half the cut, half the size of the total knee, and recovery is twice as quicker. Surgery time is more or less the same, but inside the hospital stays less. In fact, we are doing a trial where we are sending the patients home the same day after partial knee replacement with a total knee. It's not possible at the moment in this country, in the setup I work in or where we work in. So recovery time is half in terms of going home. In terms of longevity, that's the main thing now. People used to think that if I'm having a partial knee replacement, does that mean I'll have to have a full later on in life? The answer is no. It's like a building which is crumbling, breaking down. If you address the issue, it should not come down. So the whole building should not crumble down. You have taken actions to correct it. So what I tend to do is I try to replace the burnout side without throwing the load to the other parts. So that means under correction, means the other part does not get overloaded. So that should not wear out. So hopefully, and then I'd spent 1 year doing my fellowship trying to find out the reasons why partial knee replacements fail. And now, over a period of time, there's been changes in the design, the instrumentation, and those things has been addressed. One of the common things was that the grout used to come out loose, aseptic loosening we call it. The modern implants, especially on the inside part, is put in without grout. So that bonds with the bone, which means the more you load it, the more the bone grips the prosthesis, so it does not loosen out, number one. There used to be a problem with the plastic spinning out of the place. So now they have changed the design when one wall is longer than the other, so it does not spin around the axis. And then understanding that, yes, if you have got a choice between putting the plastic in a bit too tight or a bit too loose, always go a bit loose. Keep it under corrected to the inside part so that it does not throw the load to the other side, and also prevents the plastic from getting pinged out. So over a period of time, things have been refined, and now the expectancy of a partial knee is to last as long as a total knee replacement, and maybe more. And I believe that most people would be living until the late 90s. So you do one operation so they don't come to a stage where they need a total. Or if a partial knee has lasted 20, 25 years, from the age of say 45 or 50, by 70 they get a total knee, and that will see them out without going into big revision territory. So that's my philosophy, treating in a stepwise manner and trying to preserve what is natural and what's still in good nick and can still perform a function better than an artificial knee. Not 100%, but better than an artificial knee. And also I tell people that live with the natural knee for as long as they can. Like say, within the limits of discomfort. But if say somebody has got a medial compartment arthritis, they can't walk 100 to 200 yards, then yes, they need it. Or they can't enjoy the life, then yes, it's needed. So it's individual to a person. What are they expecting from life? What they do with the knee? And so the advice is based on an individual basis. But overall, doing a partial knee replacement does not necessarily mean that it needs to be revised to a total knee. On the contrary, like a building which is crumbling, if you take corrective action, it should not get completely arthritic.